Good evening, everyone. This is Dr. Tofi. I'm joining you on yet another Hernia Talk Tuesday. Today's guest is Dr. David Kerpata. He is a general surgeon specialist in hernias. I've known him since he was in training. He currently heads the Chronic Groin Pain Clinic at the Cleveland Clinic in Ohio in the United States. We'll be joined by him shortly. As you know, this is simulcast on Facebook, so please enter any of your questions to Dr. Karpata. We will focus our entire hour on groin pain only, and this hour will then be broadcast on YouTube, and you can share it with your friends. What I will say, though, is Dr. Karpata is in surgery and just finishing up taking care of patients. So he's joining us by audio, but we can't see him on video. But I do thank you, David, very much for joining us and taking the time.
Well, thank you for having me. Just want to make sure you can hear me, correct?
I can hear you perfectly. Now,
okay.
It's 7:30 at night your time, so you've been operating really late, looks like.
That's right. And good news, everybody, I am not actually operating at the moment. I am finished.
Yay.
But I'm walking out. So,
okay.
But I'm happy to be a part of this.
Excellent. So, Dr. Krpata, you're a general surgeon by training. You then did a fellowship and then continued on in like the hernia world. Is that about right?
That's correct. Yeah, I did my training in Cleveland, Ohio at University Hospitals, and then my fellowship training at the Cleveland Clinic in abdominal wall reconstruction.
And then you stayed there.
And then, yep, I've been here for 5 years.
They kept you, which is always a good sign.
Yep.
So tell me a little about your chronic groin pain clinic. It's very unique. It's built on experience with, other, like breast cancer has these multidisciplinary clinics, a lot of oncology. We've never really seen one in hernias. I believe yours may be the first one. Can you just walk me through how you developed it, what the groin pain clinic is, what patients may expect when they come to you?
Yeah, so, this is something we started a couple of years ago. And one of the main reasons why is that care of, especially associated with inguinal hernia repair.
You're going in and out.
I'm sorry.
One more time.
I'm sorry.
Go ahead.
As you take care of people with chronic groin pain, you start to learn that there's more factors involved than just the operation or the mesh that they had. And it can be related to psychosocial issues. And really, there's also other causes of groin pain. And so the best approach is to really try and take the patient in a more complete overview. And so when patients come in, they'll not only see a surgeon, but they'll also get imaging and they'll see a pain psychologist to start off with.
Okay.
And then what we do is we actually meet and talk about each patient individually and assess what is the best approach, whether it's going to be medical or if it's going to be surgical, or if there's additional interventions that we want to consider.
So when they make the appointment, what's the average time they spend with you all?
Yeah, when somebody comes in, they're typically here for a morning, and they'll be here for 3 hours to complete all their visits. Mm-hmm. And a lot of people come from out of town for these, so it can actually be very nice for them because they can get everything done in one visit rather than having to come multiple times.
Right. And how much of the data that you see is sent to you ahead of time? Or I should ask maybe a more open question. When they contact you, do you gather everything ahead of time, or they just show up the day of and you figure it out when they come? What's the process?
Yeah, so when people come in, sorry, there's a little bit of background noise, so let me get it.
It's okay. For those of you that are listening,
we typically go through a process of gathering as much of their past surgical history and some of the medical history as we can.
Yeah.
So we'll usually try and get their operative record.
Right. I'm losing you again.
Some of the potential causes of the pain.
Huh? I'm losing you, David.
Have a full evaluation with our pain psychologist. So it's a pretty complete and thorough evaluation from when they sign up to when they complete it.
Okay, you got cut off a little bit. So when they contact you, does your office have like an intake form or like a system to gather all the data? And then when you do gather it, do you all meet before the patient or after you see the patient to come up with a plan of care? Or both?
I'm sorry, could you repeat the question?
Yeah, so I'm just trying to understand the process to help the patients understand like what they should be up to. So when a patient contacts your office, is there a system where they gather all the data, and then do you sit down as a team to look at it ahead of time, or is it a team effort after the appointment visit? And when do they get the plan of care? Is it the same day or later?
Yeah, so when patients contact, which is something that they can either do by calling the office or through the Cleveland Clinic website, it's clevelandclinic.org/chronic groin pain,
Okay.
which will get you all the information for the groin pain center. Well, once they initiate that process, we set up everything as far as their appointments and get everything beforehand. Depending on what the circumstance is, sometimes we'll review more of the records beforehand in terms of some of the operative reports to see if maybe we want a different imaging modality, because most commonly we'll have people come in and get a dynamic ultrasound, but in certain circumstances we might want to get a CT scan instead. And so there is some evaluation beforehand, but the majority of that is going to occur on the day that they come in for their visit.
Okay.
And what's somewhat unique is that we're really not trying to we're not trying to have each provider give their own individual plan to the patient. We meet afterwards to discuss the patients, and then I contact everybody either later on that same day that they visit or the beginning of the following week with their multidisciplinary approach.
Okay. Okay. And do you also offer virtual consults? That's one of the questions asked.
Yeah, we do have some capacity for doing virtual consultations, and I think that's always that's a good way to start some of these. But what I have found is that the physical exam on patients for chronic groin pain is so incredibly important,
right,
that it does offer an initial link to see maybe if it might be worth it to come in. But a lot of times that just leads to an in-person visit for more thorough evaluation.
Yeah, that's been my experience too. One of the questions posed is, do you tend to see patients that have mesh-related chronic pain, or do you see people who've had hernia repairs with chronic pain, but they've never had mesh, like a Schuldeis or Bassini or McVeigh or DeSarda, whatever the tissue repair is?
Yeah, so chronic groin pain patients come in all versions.
Yeah.
And it can be after mesh repairs. I've seen patients after primary tissue repairs. I also have seen patients for chronic groin pain who have not had any inguinal hernia surgery before, or right. Other kind of not uncommon reasons would be patients who have had abdominoplasties, patients who have C-sections that they get neuropathic pain associated with their scar formation.
Yeah, exactly. That's very true. We've had some questions submitted ahead of schedule through the different social media outlets. I'm going to review some of those. So you mentioned that you've seen people with mesh with groin pain, without mesh with groin pain, or just groin pain for other reasons. Can you just go through a list of what kind of groin pain, or what's in the differential diagnosis of someone who's never had surgery who has groin pain?
Sure. So, in terms of people who have never had any surgery, there's probably three main buckets that we would consider. Non sort of musculoskeletal relating to the groin areas would be related to their back. So I always consider if somebody's had back trauma or past back or surgery. Also from the hips.
Yes.
People don't realize that they can get pain that feels like it's in their groin, but it's actually occurring within the joint of the hip. And so it's just more of a deeper type groin pain that they can actually be sensing.
Yeah.
And then more towards the musculoskeletal would be something like a core injury, or what is probably more commonly known as like a sports hernia. And we consider that as well.
And if they come to you, let's say you determine their groin pain is from the hip, when they come to your clinic, do you then refer them to one of your own doctors? Do they see them same day, or what's the process for your clinic?
Yeah, I think in an ideal world, I would always have an orthopedist available for me at my beck and call. But unfortunately, they don't necessarily need to see everybody who comes in. So It's not the best utilization of their time. So what we typically would do, we'll refer to one of our orthopedists, or if somebody's coming from out of town, I have no problem with them seeing an orthopedist that's closer to their home as well. But I usually want to have some evaluation by an orthopedist to do a more thorough look at somebody's hip, or at least rule that out as a possible cause of the groin pain.
I have a smart question for you. Look at this question. It's so smart because this is the first part of the question. So I'd like to get your thoughts. So this patient wrote, I've heard that pre-op pain is a predictor of post-op pain. I've heard this also multiple times. Do you feel that that's true? What are your thoughts about that statement? And then I have a follow-up question to that.
Yeah, so I do think it is a predictor, but and I think it's probably for one of two reasons. The first is that you either are misdiagnosing the cause of the pain and it's not from the hernia. And so I'm always asking people about what the pain experience they had before the operation and how it was immediately afterwards, and if it changed at all. Because usually if somebody had the same, they said, I got my hernia repair and nothing changed. Usually, maybe they had a hernia, but we're misdiagnosing what the actual pain is coming from. And so I'm going to focus more on some of the other primary diagnoses for groin pain, spend much more time trying to evaluate their hip or their back or find other potential causes. The other side of the coin is that people who maybe have a history of chronic groin or a history of chronic pain or have nervous systems that may be more sensitive are set up to also have more sensation from their hernia repair. So they're set up to have more discomfort with an operation.
Yeah, I understand that. Yeah, that's a small population though, I think.
I agree, yeah.
Yeah, but the reality is we really don't know. We don't know. It's the pelvis and nerves are so complicated. They talk to each other. Everyone's body acts differently. I feel that we don't know enough. One problem I have with this statement is, pre-op pain predicts post-op pain. And so then a patient will have post-op pain, will go to a surgeon, and they're told this kind of idea, which is somewhat based on data, but it's not very clean data. And they kind of blame the patient, like it's the patient's fault that they had post-op pain. Well, you had pre-op pain, so we're surgeons, we can only do so much. And I feel that it doesn't help the patient get the care they need necessarily sometimes, because it's just discounted that therefore there's nothing to do. It's just like the way you are. And in my experience, most patients have a treatable problem when they have post-op pain.
I agree with you completely. And I think that that's one of the key parts, is that recognizing that just even if those are predictors of post-operative pain,
Right.
It doesn't mean that something can't be done because you're experiencing pain.
Yeah.
You still deserve a thorough evaluation. You still deserve that workup. You, as a patient, you should not be ruled out as somebody who can be helped just because you were experiencing pain before the operation occurred. It's just, in my mind, it's something to consider, because it lets me think about what the potential causes are,
Yeah.
and it may change my approach, but I still think that it's, patients should not be written off for that reason.
I agree. So the follow-up question is, so this is a two-part question. So is there a way patients can reduce their chance of post-op pain? That's a smart question. I don't know that we know that.
Yeah, I would tell you that if you figure it out, you're really going to help a lot of people.
This is true.
I wish we had the answer to that.
Yeah.
Right now,
Yeah.
I don't think that there's a great way to predict it or to try and reduce it. But I think it's probably a great area for focusing future research on when it comes to pain and surgery.
I agree. I think we know that there are certain risk factors for like a hernia recurrence. So yeah, if you don't want to have pain because your hernia recurred, then, treat your chronic cough, don't smoke, don't use nicotine, don't get constipated, like that kind of stuff we know. But in a more kind of global way, can someone reduce their chance of postoperative pain? That's tricky. I would
Yeah.
say make sure you're seen by a talented surgeon who chooses the right or the best, option for you in terms of what you need to have done.
Yeah. Yep.
Okay, so here's the smart part of the question I really like. So this patient follows up and says, okay, great. I've heard about watchful waiting. So what am I waiting for? Am I waiting for pain or increase in size? And if I'm waiting for pain, you just told me that pain is a risk factor for post-op pain. So why is watchful waiting okay? What do you say to that? And what are they waiting for?
Yeah. So if we always consider exactly what a hernia is, I like to explain it as simple as possible, in that a hernia is a hole that allows things to go through it that shouldn't.
Right.
And that thing that you really don't want to go through it that shouldn't is your intestines.
Right.
And if that occurs, that's a surgical emergency. So when we talk about watchful waiting, we're talking about people who have a what we call minimally symptomatic or asymptomatic small inguinal hernia,
Yeah.
where their risk of an incarceration or their bowel getting stuck in there is very low percentage. Less than 1% over 5 years, over 10 years, probably about 2.5%. So the real question there with watchful waiting to me is it safe for me not have surgery and not end up in an emergent situation?
Mm-hmm.
Now, whether or not you're going to develop symptoms along the way while you're waiting, that does occur. That occurs in 60 to 70% of patients over a 10-year period.
Right.
So people can kind of consider that. As hernia surgeons, we also consider that in terms of defining whether or not somebody should have a surgery based on some of their comorbidities and whether they can tolerate an operation. And is it actually just safer for them maybe not to have an operation because the risk of incarceration or bowel getting stuck in is actually pretty low?
That's correct. Yeah, very good. All right, we have some more questions coming in. With regard to the patients that you see for chronic groin pain that have had a mesh-based hernia repair, have you noticed that any one particular type or style or type of repair presents to you or not? Or material?
So one of the things that I always try to avoid is plugs, hernia plugs, or bilayer meshes. Essentially, the more bulk of mesh, I think the higher the risk of having some pain associated with it, and specifically for plugs, where it can have sort of that mass effect where it compresses or pushes on areas. I do feel like the mesh may be more associated in those circumstances.
Yeah, in my practice too, I feel the plug and the purling hernia system with the two-layer meshes, those are more likely to cause mesh-related complications where it folds or gets stuck to organ systems like the spermatic cord that it shouldn't be stuck to. But we actually looked at that. I wrote a paper called Why We Remove Mesh, and I looked at all the meshes that I removed, both for groin and non-groin. And I thought, anecdotally, I thought that the plug would like be so much more than everyone else. But actually, the number one most common mesh that I removed was just flat mesh, just to show you that it's possible that also most repairs are with flat mesh. So my
Yeah.
interpretation was that if you look at it, if let's say 30% of, I'm going to make up this number, 20% of all hernias are made with the plug, and 80% with flat mesh, I think like something like 40% or disproportionate number from the plug had problems. But all comers, it was more common with just a flat mesh. And the purling hernia system is a specific two-layer mesh. There's a top layer and a bottom layer. It's a good idea, but like the plug, there's a lot of interaction with the mesh and the spermatic cord. And then secondly, you have to be really good at making space for the mesh. And if you don't, the mesh will fold. And that's kind of the Achilles heel of that mesh.
Yeah, I think by principle, you always want to try to avoid folding, avoid bulk or mass,
Yeah,
in order to try and reduce pain.
correct. Going back to your statement about groin pain and hip disorders, so I understand, or sorry, patients understand where the hip is, and it could kind of interact in the same plane as the groin. So the groin that I explain is kind of where if you can see where your leg and your attaches to your torso, there's a crease there, that area, and above that, a couple inches above that, that we generally call that the groin. When you see patients with hip problems that are causing the groin pain, how far medial, like, do you notice that they get pain? Do you ever see them with testicular pain? Can they be pain in the midline or pubic symphysis, or not really? That's a question from one of our viewers.
Yeah, I don't find that it tends to cross to the midline or that it causes testicular pain. I think testicular pain is usually one of those things that helps kind of rule out hip as one of the causes.
Yeah.
And a lot of times, people have seen their orthopedic surgeon as part of the, if they've had any hip issues in the past. And I will say that when somebody's had a hernia repair and they start to have pain in the groin, even if they see an orthopedist, it's not uncommon that the orthopedist is going to defer to the hernia repair and say
Yes.
that is probably more the cause.
Yes.
And I've had patients where we've removed the mesh and we really haven't had any significant improvement in their pain, and then they go on back to their orthopedist and get their hip replaced or another hip operation, and then they get resolution of their pain.
Yes.
And unfortunately, sometimes just because inguinal hernia repairs and mesh get a bad name, they also get cause and the blame for a lot of it, even though people from their own specialty might not realize that they're missing the diagnosis as well as something like hip as the cause.
Yeah, I would say my experience, as you know, they're really talented general surgeons or hernia specialists, and there are others that don't really think outside the box. And the same is true for orthopedic surgeons. I have a lot of patients that have been through the orthopedic route, and because their groin pain didn't perfectly match what the textbook says about a hip labral tear or a hip disorder, they were told it's not your hip, it's your hernia, for example. And then you send them to a hip specialist, let's say, that does think outside the box, is a bit more talented in their diagnostic abilities. And they said, no, this is hip, it's just, maybe a little atypical. And they get their hip repaired. And, I have a handful of these specialists in my back pocket that I rely on, because just because you went to one doctor and they said it's not that, I feel that patients should do a little bit more research or be open to getting a second opinion, whatever the question is. In our case, hernias or groin pain. Do you see that too, where the patients come to you with all these, urology said no, gynecology said everything's normal, orthopedic says everything's normal, but then you actually find it's not a hernia problem, it's a gynecologic or orthopedic or urologic problem. It was just missed.
Yeah, that happens. And to your point about the specialist, even if somebody has had an evaluation by an orthopedist and then they come to see me,
yeah,
if I really feel like it's related to the hip,
yeah,
or I think that it's really not related to the hernia repair, then I will recommend that they get a second opinion, and just to hear out somebody else and make sure that they do get to a specialist. Because again, like you said, not everybody's as keen in on some of these findings, and maybe some of these patients may come with a history of pain and they get written off. So I think it's important that sometimes second opinions are also key factors in figuring things out.
Yeah, I totally agree, and they should be open to that. Here's a question: can a hernia permanently damage the body or nerves? Let's say you follow watchful waiting. Can you have permanent damage by not repairing that hernia?
From a nerve perspective, I don't believe so. Obviously, you would not want to watch a hernia till it was so large that it became something overly complicated to repair. But we repair some pretty large inguinal hernias, so I don't even think you could watch it to a point that we wouldn't be able to do that.
Right.
But I think with reasonable expectations, I don't really think that by watchful waiting you're going to do damage to yourself. And if you look at the studies that actually look at those and compare surgery versus watchful waiting, people who waited longer for their operation did not have more complications as a result of or when they did cross over to have a hernia repair.
Right, good to know. Yeah. There's a Dr. Robert Wright. He does a lot of hernia repairs open, and he has an interesting group of patients. So he routinely cuts the ilioinguinal nerve, which, as you know, is a known technique. But then he's been sending these to a pathologist to look at actual, like, more than just look at the nerve and study the nerve. And he's found almost like a pressure necrosis, a neuropathy in those nerves. And he feels that the hernia pressure on the nerve can cause like a pressure impingement, kind of like how a disc will push on a nerve. And therefore, he feels that not only was that the cause of the pain, but it may contribute to postoperative pain if you leave that alone. And that may be a subset of why patients have postoperative pain, is because they have a damaged nerve from the hernia. It's hard for me to believe that, but he does have data. It's pretty interesting data, actually.
Yeah, I think that's certainly interesting, and I applaud the effort to try and help figure out how we can help to avoid chronic pain in patients with hernia repair.
Right.
We do know from large series of studies that there's in favor of it and not in favor of it. But
Right.
if you kind of group the studies together, that there hasn't been a real benefit shown with routinely cutting somebody's nerve at the time of their primary operation. So, if that is true, then I guess to me, maybe there's not as many neuropathies occurring, and that this appears to be a more random effect.
Yeah. Yeah, I agree. Good point. Another question: is a hernia harder to repair the longer you wait? Let's talk. We're only talking, just for the audience, we're only talking about the groin this hour. So is a groin hernia more difficult to repair the longer you wait?
I think if you wait a really long time, it can be a much more challenging operation. But for the most part, if we're talking about, let's get specific and say, okay, I noticed a hernia, and is my hernia repair going to be harder because I wait 3 months to have it repaired? No. Is it going to be harder because I wait a year to have it repaired? No.
Correct.
Is it going to be harder if I wait 5 years? Probably not. And the studies about watchful waiting would show that it's not more complicated to fix. If you wait 15, 20 years, then maybe.
I mean, yeah, if it's down to your knees, then that's definitely a different operation than when it's like just a visible bulge.
Yeah.
Yeah. You have a lot of fans, by the way, logging in and saying hi and how much they love you and how you saved their life. So good job on that. I know that I've seen a lot of the patients that you've seen. I'm very impressed with the quality of the consultation you offer the patients, the amount of radiologic expertise that you offer with the 3D ultrasound is really amazing. I hope that somebody in your group can teach other radiologists to do the same, because that's just a fantastic ability to look at all the tissues in the groin and nerves and mesh and the muscles and really understand the dynamic of the groin. We can't get that information with most other studies.
Yeah, I am very fortunate to work with a very talented group of musculoskeletal ultrasound radiologists who we've actually worked pretty closely together to make sure that we're looking for everything that we want in a nice, complete groin evaluation. And I think one of the things to point out to people who might, if they're considering, well, how is this ultrasound going to be different than what I've got in the past? This is, if you come in and get this ultrasound, it's usually between 45 minutes and an hour long evaluation of the musculoskeletal system, how the muscles insert onto the pubic bone, looking for nerves, looking for hernia recurrences, as opposed to the routine ultrasound, which is usually a 5-minute, do you have a hernia or not? So it is different. People will often say, well, I've already had an ultrasound. Do I really need to get another one?
Right.
But this is, you're right, this is a different ultrasound. It's very thorough. And I'm very fortunate to work with some great radiologists.
And does the tech do it or the radiologist does it?
So the techs, they do it, and then they sit down, routinely the way they would normally do. They sit down with the radiologist, and because, I've actually had, I don't know if you're a class, or I sat down with all of the radiologists, as well as the techs who do these, and I've explained to them what I'm looking for, and I've shown them pictures of what we see in surgery, correlating to some of the findings that they've demonstrated on their imaging. And I think an important part of that is, number one, it engages the technologist more, but it also makes them feel like they're really a part of an individual patient's care.
Yeah. Yeah, and I think if the more they know about what we do, it really helps them be able to help us in evaluating our patients. I agree. I have one radiologist who is older, who really enjoys ultrasound, and he does it himself. And so if I can get all my patients to see him, that would be the best. He's really, really great. And I hope he never retires, or at least not until I retire, because he's awesome. So let's talk about mesh allergies. Last week we had Dr. Robert. He's a rheumatologist and specialist who's written a lot about allergies and autoimmune problems related to implants, anything from a hip implant to breast to mesh. And he's got some really interesting thoughts. He worked with the surgeons over in the Netherlands and looked at hernia mesh. He's looked at other mesh as well. Learned a lot from him. What's your thought on, do you see patients that are somehow reacting to the mesh? I'm not talking about local pain or meshomas or nerve entrapment. I'm talking of like systemic head to toe changes with brain fog and chronic fatigue and joint pain. Do you see that? And do you have any special workup for them? What are your thoughts on this subset of patients?
Yeah, so this is, first off, I think that that's all extremely interesting. And I think I would like to first say I am not a rheumatologist or an allergist or immunologist. And so I personally am very interested in that, but I think that it is an area that we have a lot of work to do as hernia community and hernia surgeons. And I've read some of that material, and I have seen patients who have systemic complaints, rashes, generalized fatigue, myalgias, and myositis type complaints. And I would say that, I still sit in the boat of I don't know what it all means, but I really want to help try to figure it out. And so what we've started to do more frequently is when patients have a constellation of symptoms like that, we get a testing panel to try and look at their immunology and see if there's markers that the rheumatologist would normally look for in things like rheumatoid arthritis and some of those autoimmune diseases, because there's a concept of an autoimmune induced response from mesh. So the shorthand for it is called Asia. And we call it our Asia panel, which has about 10 studies, blood work studies that try and identify this. And we try and get these labs before their operation, and then we remove the mesh, then repeat them after the operation and see if we're getting any change.
And how far after surgery do you do the second study?
The goal is to do it at around 3 months. Once they've healed up more from the actual operation.
Yeah. And do you know what's in this panel, this Asia panel?
I'd have to get my immunology hat on to give all the proper names, but the ANCAs, there's the immunoglobulins that look for immunoglobulin G, A, M. It's a whole panel. Antocardiolipin antibody. There's a whole host of antibody response immunology that we're essentially looking for. And the idea is trying to look and see, is your body reacting to the mesh as an autoimmune type disease?
Right. Yeah, it's all, I do similar tests, and the typical autoimmune markers are, in my experience, have all been normal. I have not been doing any immunoglobulin studies, but my allergist does, and sometimes they're very hypo immunoglobulinic, and there are some interleukin studies that Dr. Tervert does. So all very interesting, all kind of up and coming work. Yeah, that's pretty complicated. I hope that we figure it out.
Yeah, I think it's interesting, but really complicated, and I am not sure which direction it's going to go.
Yeah. Okay, so obviously you treat patients that may have a mesh reaction.
Yeah.
Yeah. Okay, more questions. Let's talk about some sports hernias or rectus strain, adductor strain injuries, core muscle injuries. What's the process when they come to you for that?
Yeah, so if you're coming more for a sports hernia or core injury, we tend not to need necessarily the complete chronic groin pain experience per se. You still get the ultrasound, and that for me, for chronic groin pain evaluation for a sports related hernia or core injury, I do lean on the ultrasound again. But I don't feel it's necessarily as important for them to see our pain psychologist. You certainly may end up still seeing an orthopedist or a back specialist, because still the concept of core muscle injury I think it's a lot of people hear it, and so any sort of groin pains sort of get referred as sports hernias, but may still, again, be one of those other primary diagnoses.
Got it. And then when you do these ultrasounds, do you notice it's any different in women than men? Are women more difficult to assess or view their anatomy for a hernia on ultrasound?
That is a good question. I'm not. I would have to ask our radiologists and the technologists if there's any difference. They haven't mentioned it to me, so I don't know the answer to that. I don't think so, but I'd have to ask them to fully know.
Okay, good to know. There's one patient that says that she does decompression for her lower back pain with electrostimulation afterwards. These are like manipulations. And then when they apply the electrodes to her lower back and turn it on, she feels a sensation from her back to her groin and gets chronic pain. Is that something that you've heard about?
That to me would be a unique sort of clinical situation that I'm not 100% aware of what that would be related to.
I know that SI joint pain or sacroiliitis can cause groin pain and inner thigh pain. So sometimes one of the reasons for groin pain is actually from the back, like you mentioned earlier, but not necessarily the spine. It's actually from the sacroiliac joint. Maybe that's parts being stimulated and that's why it's causing the pain. I don't know.
It's a good thought.
Thank you. Okay, next question. We got so many questions today. My mesh has been removed. I'm worried about recurrence. What can I do to protect myself? What do you teach your patients?
Yeah, so this is also another good question. So first off, when I remove mesh, I most commonly will not put new mesh back in. Mm-hmm. And part of the reason for that is I'm doing the operation more for pain than for the hernia itself.
Yeah.
And I always talk to patients about the risk of hernia recurrence after that, because it is certainly higher than if I put new mesh in there. And I would fully admit that patients are going to be at higher risk in that setting.
Yeah.
That's the whole reason why we use mesh in the first place.
Correct.
So there's a real risk of getting a hernia recurrence if you have your mesh removed.
Yeah.
And I always tell people after the operation, the most important thing is to take it easy for the first 6 to 8 weeks. And I really try and have them avoid heavy lifting, nothing greater than 15 pounds. Because the concept is that you're really putting two tissue planes together that need to heal. And if you strain that too quickly or overexert and cause the suture that's holding it together to rip or tear apart, as soon as that separates, your body's not going to decide to heal it itself.
Yeah.
So you're going to get another hernia. As in with any sort of mitigation technique for trying to avoid a hernia, trying to avoid strenuous activity is key. Managing things like cough, constipation, difficulty urinating, and difficulty, with some things like BPH. Those things should be managed in an attempt to try and prevent yourself from getting hernia in the future. I also advise people, though, that hernias shouldn't run their life, and that they need to live the life that they want to live and do whatever it is they want once they've healed. And if they get a hernia back, then I'll deal with it. And you leave that part up to me. I don't want people to necessarily stop living because they're afraid they're going to get a hernia back.
Mm-hmm. Yeah, I agree. We have a patient with sweet disease. It's some people consider that autoimmune. Others, it's like a skin problem. It can be triggered by different illnesses or infection. Maybe mesh. We don't know. Would you in patient with sweet disease? And I've had one patient. Would you be okay putting mesh in, or do you have any hesitancy putting mesh in any specific type of patient?
I probably wouldn't hesitate too much. I may alter my mesh choice slightly by using maybe something that's lighter weight so that there's more or less material density.
Yeah.
I don't know if that would make a difference or not. But we do put mesh in patients who have autoimmune diseases. A common population that has a big issue with this would be patients with inflammatory bowel disease.
Right.
And there's a lot of, research I think needs to go into this, because these patients have a lot of abdominal operations and they get a lot of hernias.
Yeah.
And oftentimes they're getting mesh. And I think there is some concern by some people that, whether or not that's going to cause them worsening of their inflammatory bowel disease. I think one of the most important things is placing the mesh outside of the abdominal cavity.
Right.
So it's not in direct contact per se with the bowel. But, my current practice is that I do put mesh in those individuals.
Yeah, we just need to learn more. Dr. Tavert considered IBS or irritable bowel syndrome as part of the Asia syndrome.
Yep.
He just has really interesting data. I really enjoyed speaking with him last week.
Yep.
Okay, more questions. How often do you offer surgery for patients with core muscle injury or sports hernias? Is that something that almost always does need surgery, and do you offer that surgery? A patient is asking.
Yeah, so for core muscle injury, I am in the boat that believes the first line therapy for a core muscle injury is rest followed by physical therapy.
Yeah.
And leading to core strengthening that hopefully stabilizes the core itself. And I think that surgery should be more of a last resort for somebody with a core injury if they've failed physical therapy and rest.
Yeah, I agree. Yeah, the surgeries are not always successful. And to be fair, unless you're like a super athlete, most people will get better and do not need like the extreme surgery for that.
Yep.
Next question. So this is a complicated patient. He sent me like multiple pages of information, but basically he's a gentleman. He had mesh put in laparoscopically. He had a complication with that. It was taken out. He's had a third surgery. He's had multiple neurectomies. His original pain never went away. He's still in chronic pain and now has additional pain. He was told the next step is for an orchiectomy. Travel is difficult for him. So he's a little bit of a loss. He doesn't know what to do next. He thinks he has nerve entrapment. Maybe isn't clear why he's got so much pain. So if a patient like this emails you and says, what do you recommend? What do you recommend as their next step?
This is I get a lot of emails and letters like this, unfortunately. Yeah. So, and as you can tell by the letters, that these are not straightforward situations. So I always recommend, if that's the case, and I know you have limited resources, but if it's something that's really bothering you, if you're able to come to our Chronic Groin Pain Center and get a thorough evaluation, do that. If it's a regional issue where they're not in if they're close to somebody else who I know who might manage chronic groin pain, I will, refer to that person. If it's, maybe easier for them to get there, won't cost them as much money. But I still think that, you need in these situations when it's this complicated, even more so, you need to have a more thorough evaluation by somebody who has a lot of experience in this field.
I absolutely agree. First of all, if anyone tells you to get an orchiectomy for testicular pain, get a second, third, and fourth opinion. It's almost never a treatment for testicular pain. There are other treatments for it, but just taking out the testicle is not the answer usually. I totally agree. Yep. So I understand for people, they have children, family, financial limitations, travel may be difficult because they're in pain. But it is so important to get good care. And when you get down to a situation where you've kind of you kind of exhausted the limitations in your own neighborhood or state, whatever the situation is. I can't tell you how important it is to invest the time and energy and financial whatever to seek care that is highly specialized by doctors that do this all the time. So it's very possible this patient never even needed a hernia repair. Can you imagine all the money they spent getting the hernia surgery, then the mesh removed, and the neurectomies, and all the time lost from work? Like, just think of the money that was lost there. I just hope that people understand it's like chronic pain destroys your life, destroys your work, destroys your family. It is so important to invest in the time and expenses to get rid of that chronic pain, and that's best done by people who do that for a living. And your chronic groin clinic is one of those. Out of curiosity, how is your insurance acceptance? Like, do you accept all insurances? Are you out of network, in network? What's the status for that?
I would say it's all of the above. We're not in network necessarily for everybody, but there's circumstances where people can get approval to go out of network and to be seen, but it usually requires a letter from a surgeon that's within your network who says this is something specialized where they actually need to go out of network. We don't have somebody in our network who can deal with this. So there are ways around that to get coverage, but we do accept a lot of insurances, and but we do have to work sometimes with insurance companies to try and get patients through the process.
Yeah.
And there are some times where there's insurance companies who just won't approve it, unfortunately. And that's sometimes our hands are tied in that situation.
Yeah, I agree. I think what we do is so specialized. A lot of the protocols that insurance companies follow don't really pertain to a lot of our patients. On that note, this is our last question. How come there aren't more clinics like yours?
Well, I think the most honest answer to that is managing chronic groin pain is not easy. I think most people would not necessarily view it as glamorous.
Yeah, there's no glamour in it. It's definitely not a sexy topic.
Yeah. So, I could just say personally that, I work at a center where we have a lot of specialized hernia surgeons. And so we have the opportunity to kind of look at a broad spectrum of hernia disease. And we also have the opportunity to specialize within some of that disease process. And I've been impacted by some of the positive experiences that patients have had when they've gotten treated for chronic groin pain. And even though sometimes it doesn't help people, when it does help people, I think it's one of the most satisfying things because, as you mentioned earlier, chronic groin pain, it's debilitating and it can really, really impact your life. And so if you can fix that for somebody, you can really turn around and give them sort of new life. And I've seen that, and I've had more patients shed tears of joy in my office than I have had, necessarily tears of pain. So I just find it rewarding, and I think that that's probably why. I think also being at a larger institution like the Cleveland Clinic, we have the ability to have specialized ultrasonographers. We have the ability to have a pain psychologist maybe more easily than some other hospitals that just don't have that broad of a workforce.
Yeah, we had Bruce Ramshaw on as one of our guests on HerniaTalk Live several months ago, and the importance of the pain psychologist in improving outcomes after surgery for chronic pain, or even before the surgery, really has been key, and he's done such a good job with that kind of research. I think the financial question is also important. Your facility is very astute and very specialized, but at the end of the day, they would not agree to a chronic groin clinic if it was a money-losing endeavor. And so, you know, since I've been in private practice, I've become more in tune with that. And groin pain or groin disease in general, like hernia stuff, is not considered a highly valuable disorder, and it's kind of undervalued by the insurance companies. By valuable, I'm purely talking about like how insurance looks at it. So maybe with your system where you're able to bring in all the specialists at one time, that may work. I'm really very glad that you do this, because we need more groin pain specialists and then more clinics that are multidisciplinary that can treat the patients full, because it is so complicated. It's such a complicated part of the body.
Yeah, it's very, very complicated.
So I hope that the clinic, the Cleveland Clinic, views your clinic as, you know, one of the, well, it's, I would say it's currently the leader in promoting this kind of system, but also I hope that you have a really good success rate and positive. For sure, you've had so many of your patients that already came on, and you've made such a great change. But in a very short period of time, David, I'm really proud of what you've done in such a short time. Just like what, 3 or 4 years, you've been able to make this like a solid, functional clinic. That's just a lot of work, and kudos to you for doing that, or for wanting to do it and then to go ahead and do it.
Yeah, thank you. I still find it rewarding, and so you know, anybody who needs it, I'm open. I'm willing to see you.
So how do they contact you for consultation?
Yeah, so all the information is on the Cleveland Clinic website. It's
Okay.
at clevelandclinic.org/chronic groin pain.
Mm-hmm.
Get you to the center's page. Or if people are looking to schedule an appointment, they can just call the number for scheduling there, which is 216-445-9989.
Thank you so much. And for those of you that have been with us the whole hour, almost the whole hour, Dr. Kerpata just finished surgery before we started HerniaTalk Live. He's not on video because he's walking around the hospital and trying to finish up a very, very long OR day. So thank you, Dave. I really appreciate the time. I'm glad it worked out that you can join us and answer all of our questions. And on that note, I'm going to say goodbye to you and to our guests and everyone that was involved. I do appreciate you all coming every week to Hernia Talk. As you know, I live, eat, and breathe hernias, and everyone that I bring is like a fantastic doctor and really caring and great at what they do, like Dr. Krpata. You can follow me on Twitter and Instagram at HerniaDoc. This video will be posted on my YouTube channel. You can also watch it on my Facebook homepage at Dr. Tofi. And on that note, goodbye, everyone. Have a good night. Thank you, David. I hope you're